Good day to everyone. First of all, I would like to apologize for not being able to make it during my lecture there in the PHA refresher course. But it's fortunate that I was able to regain my voice after 4 days treatment. So I just took this opportunity to make this video lecture for all of you. And let me take also this opportunity to congratulate everyone for making it this far. But of course, you need to take one last step before you become a diplomate of the Philippine College of Cardiology. So I guess this is it. After all those years of school, training, residency, a lot of exams and fellowship, it definitely all boils down to this. Probably your last exam before you go on to your practice. And just some personal tips how to pass the exams in 40 days. Probably by now you should be just answering questions, make review one day before, maybe just have some relaxation and fun, because the main work probably should have been done during your 3 years cardio fellowship. That's right. But I guess the topics for cardiac arrhythmias and ECGs for the PCCs, we have high-yield ECGs. These are must-knows for you. There's probably going to be an atrial fibrillation. In past exams, they gave a lot of AF with RVR, maybe pre-excited AF in patients with Wolff-Parkinson-White syndrome, aberrancies, of course, WPW ECGs. For sure, there will be one pacemaker ECGs, usually a dual chamber. It might be a normal or an abnormal function. What else? SVT, that's always usually part of the exams, ventricular tachycardia, and maybe one ECG on a bradycardia, whether it's a sick-sinus syndrome or a heart block. And just to show you the previous ECGs that they gave in past exams, and I do have a list of them, okay? Or there's AVNRT, AVRT, aberrancies. The Ashman phenomenon was given about 8 years ago. Flutter, WPW with SVT, location of the pathway for pre-excitation, ECGs of HOCM, okay, wide QRS, left bundle branch block, monomorphic and polymorphic VTs, of course your torsade, okay, ECGs on junctional rhythms, sick-sinus syndrome, AV block, pacemaker rhythms, some questions on troubleshooting. Several years ago, ECGs on Brugada syndrome. Last year, I think they gave ARVD. Of course, the MI ECGs. And not to forget, you might forget normal sinus rhythm. And about 4 years ago, they gave a question on doing the laddergram. And there will be cases with side questions. So you need to be aware of the clinical correlation of all these ECGs. Probably the most likely to come out in your PCC exams, if I were the examiner, are the following: SVT, atrial fibrillation, WPW, VT, bradycardia, and of course one pacemaker ECGs. And there will be side questions probably on management. Now, most likely not to come out in the PCC would be advanced pacemaker ECGs, the pseudo abnormalities, advanced function, differentiation between antidromic and orthodromic SVT, that might be beyond you, origin of your PVCs, maybe VTs and ATs, that might be too much. An EP study, they haven't really shown an EP study or an intracardiac electrogram. So probably these are relatively low yield, but of course there's always a first time. So my tips for this coming exams: don't panic. Keep cool. Imagine that you are in a heart station or in the ECG lab assigned to read this ECG. You know this particular tracing. But if you don't, pretend as if you do. And if you really don't, make a wild guess. And of course, pray. Yes. So this is what we're going to try to do for this arrhythmia workshop. I'll try to present must-know ECG tracings for interpretation and discussion. We'll present high-yield ECGs for review. We'll try to review some recall questions from previous exams and present some mock board questions. Let's tackle the high yield ECGs. Okay, SVT will always be a high yield ECGs. I think by now you should be familiar with the tracings for SVT: narrow, complex, regular tachycardia, no discernible P waves. Usually the P waves are buried within the QRS, and it comes with a sudden onset and a sudden offset. So this is your paroxysmal SVT. Of course, the pathophysiology is due to re-entry and involves an extra pathway. If it's a dual AV node, it involves the slow pathway and the fast pathway. If it's AVRT, it involves a bypass track, also known as an accessory pathway or an accessory AV connection. So for AV and RT, the physiology is a dual AV nodal physiology, causing AV node re-entry between the slow and the fast pathway. When you talk about AVRT, you mean to say that there are accessory pathways. These are invisible connections between the atrium and the ventricle, either on the right or on the left side, as capable of conducting retrogradely or antegradely, causing your SVTs. Now this algorithm is in your Braunwald, and it's just to show you how to differentiate the different narrow QRS tachycardia, the regular ones. And just to go straightly to the part wherein you have irregular tachycardia, you might be dealing with atrial fibrillation, or maybe atrial flutter, atrial tachycardia with variable AV conduction, or a multifocal atrial tachycardia. But if it's your tachycardia is regular, then you take a look at the P waves. Now, if your atrial rate is greater than your ventricular rate, okay, you might be dealing with atrial flutter or atrial tachycardia. If not, you need to analyze your RP interval. Take note that by statistics, your narrow QRS regular tachycardia, 60% of this are AV and RT. And in about one-third, it's about just due to AV-RT, and only 10% is because of atrial tachycardia. So you analyze the RP interval, and there is such a thing as a short RP interval, wherein the RP is shorter than the PR. And that is to show you the RP interval from the R to the start of the retrograde P wave. If it's shorter than the PR, you're dealing with a short RP tachycardia. And if you try to measure that interval, if it's shorter than 70 milliseconds, most likely that's AV and RT. If it's longer than 70 milliseconds, you might be dealing with still with AV and RT, but sometimes AV, RT, or atrial tachycardia. On the other hand, when you have a long RP tachycardia, wherein your RP interval is longer than your PR, these are the differential diagnoses: atrial tachycardia, the rare PJRT, or maybe an atypical AV and RT. And of course, sinus tachycardia will also present with a long RP tachycardia, and sometimes, of course, that will present with a narrow QRS, regular tachycardia. So in typical AV and RT, the physiology is that the antegrade conduction goes through the slow pathway, and the retrograde conduction goes back through the fast pathway. For a typical AV and RT, the antegrade will be through the fast pathway, while the retrograde will be through the slow pathway. And so typical AV and RT will present with your typical narrow QRS tachycardia, short RP, or maybe you cannot see the retrograde P. While an atypical AV and RT, since the slow pathway goes right back up through your, or the retrograde pathway goes right back up through your slow pathway, you will have a long RP interval, and that's will present with you with the long RP tachycardia in the bottom ECGs. So typical AV and RT can also present with what we call as pseudo S waves. These are notches in your terminal part of the QRS complex S, or in your AVL, representing the retrograde P. So these are all part and parcel of your typical AV and RT. Or they can present with a pseudo R, okay, and an upward deflection or slight notch in the terminal part of the QRS complex. That is also in AV and RT. So pseudo S, pseudo R may be AV and RT, because these are associated with a short RP tachycardia, as indicated in this larger tracing. So, of course, just to differentiate the common form or typical AVNRT, wherein you have a pseudo S or a pseudo R, and the one below would be an uncommon or atypical AVNRT, wherein you have a long RP tachycardia. And your retrograde P, the interval from the R to the P, is longer than your PR. This is an example, a Holter tracing of a patient with narrow QRS tachycardia. You can take note that initially, after the first beat labeled S, there's another PAC that conducts with a long PR interval, indicating conduction through the slow pathway, and it conducts right back up, creating a QRS complex and initiates the tachycardia. Short RP tachycardia, regular. And then you can clearly see the pseudo R patterns of the QRS complexes in the bottom tracing. So that's the PAC, a PAC with a long PR and an SVT. There's a typical slow-fast AVNRT, and that's your pseudo R. So this is your typical common AVNRT or the slow-fast AVNRT. On the other hand, when you talk about AVRT or atrioventricular reentrant tachycardia that involves accessory pathways, the circuit might involve antegradely down through the AV node and retrogradely through the pathway. And that's what you call a concealed bypass tract, wherein the pathway does not conduct antegradely, only retrogradely. So they still present with a narrow QRS tachycardia. Sometimes they present with this. Of course, you can clearly see the retrograde P, but of course it's short RP, but the RP interval is longer than 70 milliseconds, and you can clearly see the retrograde P compared to the retrograde P in AVNRT. Okay, so it's longer than 70 milliseconds. Another tracing of your AVRT. Okay, that's a measurement of your RP, which is still short, but the RP interval is longer than 70 milliseconds. Might suggest an AVRT or the presence of a bypass tract. Atrial tachycardia, which occurs in 10% of the narrow complex regular tachycardia, might present to you with a long RP tachycardia. Okay, and you can clearly see that the P waves, the interval from the R to the P is longer or short or longer compared to the P to the R, and you can measure that there. Now, some of the potential side questions are the following. What would be the treatment in an emergency setting? And of course, long-term treatment. So you need to review on that. Okay, well, what would be the treatment for SVT? So recall your ACLS and the long-term treatment. One of the favorite ECGs is, of course, your pre-excitation Wolff-Parkinson-White ECG pattern, presenting with a short PR and then the delta wave and a wide QRS complex. Okay, this is an example, again, of a pre-excitation. Short PR, delta wave, the upward slurring, clearly seen in your V2 and V3, and the wide QRS complex. The potential side question is usually to name the location of the pathways. And that one, this is an algorithm from your Braunwald. Basically, the trick is just to check the delta wave and the QRS in your V1. If you have a negative delta wave and QRS, most likely the pathway is in the right side. If it's positive, that means it's upright, most likely it's on the left side. Then the next step is to just check your inferior leads, 2, 3, and AVF. If you have negative delta waves and QRS there, most likely you're dealing with a posterior septal, whether it's on the right side or on the left side. Then, of course, anything other than that would be either in the free wall, or if it's an inferior axis, an anteroseptal, if you're dealing with a right-sided pathway. This is an example of WPW. Okay, so take a look at your delta wave and QRS in V1. This one is positive, so that means your pathway is on the left side. And then if you take a look at 2, 3, and AVF, Okay, it's actually equiphasic. It could be somewhere in the lateral wall, maybe somewhere near the septum. Okay, another tracing of a WPW. Okay, this time still positive delta wave and QRS in V1. That means you're dealing with a left-sided pathway. And you look at 2, 3, and AVF, you're dealing with a lateral pathway. Now this time WPW but a negative delta wave and QRS in V1. So that means you're dealing with a right-sided pathway. And if you take a look at your 2, 3, and AVF negative, then it's a right posteroceptal pathway. When you talk about the AVRTs, there are two forms. Okay, the orthodromic AVRT presents with the typical narrow complex SVT, short RP tachycardia, and it means the antegrade conduction is through the AV node, while the retrograde conduction is through the pathway. On the other hand, when you say antidromic, it presents with a wide QRS tachycardia. It means the antegrade conduction is through the pathway, and this is a patient with a wolf, while retrograde conduction is through the AV node. This antidromic AVRT presents with a wide QRS tachycardia and might be difficult to differentiate from VTAC. Hence, it is one of the differential diagnoses for a wide QRS tachycardia. So one of the recall side questions in some of the recent PCCs, of course, the mechanism of arrhythmia in the WPW is, the answer is reentry. So this is an example of SVT, and this is actually in a patient with a bypass tract. So this is an orthodromic SVT. Okay, so that means it's a narrow complex tachycardia. Antegrade conduction is through the AV node, retrograde is through the pathway. On the other hand, an antidromic SVT will present with a wide QRS tachycardia, wherein antegrade conduction is through the bypass tract, retrograde through the AV node. And it might be difficult to differentiate from VTAC, but there are algorithms for these, and that one I leave for you to review. Of course, we'll have some discussions on VT later. A sure to be shown ECG, of course, is an ECG like this. Okay, narrow complex, irregular, no discernible P waves, and you can see your fibrillatory waves. This is your atrial fibrillation. So atrial fibrillation is a very common condition. And one of the exams a couple of years ago asked about this particular tracing, wherein you have on an AF with RVR, and then you have this wide complex right bundle branch block pattern consistent with what we call as Ashman phenomenon. Okay, so try to review on the pathophysiologic mechanism of your Ashman phenomenon. Multiple choice. Which of the following is true regarding atrial fibrillation? A, can be treated with catheter ablation at the cavo-tricuspid isthmus, 95% success. B, paroxysmal type, treated with left atrial pulmonary vein ablation. C, not amenable to catheter ablation. D, conversion to sinus rhythm improves mortality. Well, the answer here is letter B, and that's actually the ablation strategy for paroxysmal atrial fibrillation. Okay, pulmonary vein ablation or pulmonary vein isolation. The statement in letter A, this is actually the ablation strategy for atrial flutter. All right. Recall question. In paroxysmal AF, the most likely source of abnormal automaticity occurs at. What is the answer? Well, the answer here is letter A. Okay, pulmonary veins. That's the source of your firing of the one that triggers your atrial fibrillation, and that's why the ablation strategy is to ablate or isolate the pulmonary veins. Okay, another recall question. The drug used as pill in a pocket for AF is, okay, that's letter B, flecainide. Okay, we do have flecainide in the market, and it is a useful drug for patients who have paroxysmal AF, and you can always have them take flecainide when they have acute attacks of AF. Now, sometimes atrial fibrillation can present with regular slow rhythm. Okay, this is atrial fibrillation with complete heart block. So, of course, we all know that AF presents with irregular rhythm. But when you have a tracing like this, you're sure it's AF with those fibrillatory waves. But it is slow, and it is regular. And you know that there's complete heart block. And the ventricular rhythm is driven by either a junctional or a ventricular escape rhythm. So AF with complete heart block. Okay, what's this? This one, regular rhythm, and you can clearly see the P waves. You could look at the inferior wall, inferior leads. You can see your beautiful sawtooth flutter wave. So this is atrial flutter with 4:1 AV conduction, and of course you have right bundle branch block. So for atrial flutter, you don't call it AV block. You call it an AV conduction because the block is usually functional because of the refractory period of your AV node. So this is atrial flutter. So sometimes you can have atrial flutter that presents something like this. You might misdiagnose it because it's a narrow complex tachycardia, regular. Okay. In chest leads, you might not see any P waves, but if you take a closer look at your inferior leads, you can actually see your flutter wave. So this is atrial fibrillation, atrial flutter with 2:1 conduction. Okay, it might be misdiagnosed as SVT, so be careful. Of course, in all these narrow complex tachycardia, including atrial flutter with 2:1 conduction, you can give your adenosine and it will unmask your flutter waves. It will not terminate your flutter, it will just create AV block and unmask your flutter waves. So it is still diagnostic. Okay, this is another tracing of atrial flutter. Okay, take a look at your 2-3 AVF, and this one is atrial flutter with variable AV conduction. Okay, another example of atrial flutter, but this time with very slow regular QRS complexes. So you call that atrial flutter with complete heart block. Now, once in a while, you'll get to encounter this very nice ECGs, irregular, fast. You don't seem to have any discernible P waves, but you can clearly see these wide, ugly QRS complexes that seem to have a delta wave. So this is a pre-excitation, AF with RVR, or pre-excited tachycardia. So when you see this, automatic, it's WPW syndrome. Another tracing of your wide QRS, rapid pre-excited tachycardia. Okay, also known as the fast, broad, irregular tachycardia. Sometimes you might misdiagnose this as just atrial fibrillation, and the mistake there is to give this patient adenosine or maybe give the patient verapamil, and that might deteriorate or cause deterioration of the patient. So you don't do that for pre-excited tachycardia. Okay, so this is another example of rapid pre-excited AF. Okay, ugly, broad, irregular tracings. So WPW syndrome presents with either a regular QRS tachycardia, or in rare cases might present with rapid pre-excited atrial fibrillation. Now, in all exams, there will always be a tracing like this, a wide QRS regular tachycardia, consistent with ventricular tachycardia. So be familiar with the morphologic patterns of ventricular tachycardia, the different criteria, from the Brugada algorithm to the Veracay algorithm. I leave that to your reading. Okay? But maybe, as a rule, if you see wide, complex, ugly, regular tachycardia, most likely that's a ventricular tachycardia, such as in this ECG. Okay, this is another tracing, right? Wide, complex QRS, tachycardic, regular. Okay, so question. Other than VT, what are other differentials for a wide QRS tachycardia? This is very important. So a sinus tachycardia with a bundle branch block can present with wide QRS, as can SVT with bundle branch block. And of course, we've discussed pre-excited tachycardia. Okay, sinus tach with pre-excitation or pre-excited AF, and that will present with wide QRS but irregular tachycardia. Fourth differential is an antidromic SVT, which I mentioned earlier. Very rare, a nodoventricular Mahane tachycardia that also involves a rare pathway. And of course, lastly, pacemaker-mediated tachycardia is also a differential. So just to show you that there are other differential diagnoses other than VT for a wide QRS tachycardia. Now, I usually use this acronym, the ECG signs in wide QRS tachycardia in favor of your VT, and basically similar to your Brugada algorithm. Okay, A stands for AV dissociation. Okay, you see AV dissociation, most likely you're dealing with VTAC. B will stand for beats, capture and fusion beats, favor VTAC. C, of course, is the concordance of your QRS. Okay, ventricular concordance in your chest leads, most likely you're dealing with VT. And of course, the wider the duration of the QRS, most likely that's VT. What does E stand for? That's the others, no? The morphologic QRS patterns, which I will leave to your reading. So this is an example. I just took this from your book. This is a wide QRS tachycardia. And you can clearly see that there are episodes of capture beats in between the narrow QRS complexes and fusion beats. Usually capture beats are beats captured from a normal sinus beat, and they present with a narrow QRS, while a fusion beat would be somewhere between the width of the QRS of the VT and the sinus beat. So a little narrowish than the wide QRS. So this will favor ventricular tachycardia. So this is another tracing of wide QRS tachycardia consistent with VT, and the arrows point to your P waves. So really demonstrating that there is AV dissociation consistent with VTAC. Okay, so that's the encircled beats are your sinus captured beats, the narrow QRS, and the ones labeled F are your fusion beats. Okay, take note that your fusion beats have a different morphology compared to your sinus beats. They are a little wider, but they are narrower compared to the typical QRS complex of your tachycardia. So this is to demonstrate ventricular concordance. You just check your chest leads. No? If all the QRS are positive or negative, and that is consistent, usually favors ventricular tachycardia. Okay, this is another tracing of your VT. Take note of the ventricular concordance in your chest leads. All of them are negative, so this is ventricular tachycardia. Now, I'm not going to dwell on all these algorithms, but on the left side is your Brugada algorithm, which I'm sure most of you are very familiar with. Okay, looking at the RS complex in all precordial leads, the R to S interval of more than 100 milliseconds favoring VT, the presence of AV dissociation, and your morphologic criteria for VT. So take time to read all those criteria. On the right side is your Vericay algorithm, which just uses your AVR. And quite a simple algorithm is if you see an initial R wave in AVR, most likely you're dealing with VT. And if not, if your initial R or Q wave of more than 40 milliseconds is present, then most likely you're dealing with a ventricular tachycardia. So an example of using the AVR algorithm, the Vericay, looking at your AVR, no? Initial R wave, then you're dealing with ventricular tachycardia. So an example, this is wide complex tachycardia. If you just use your Vericay algorithm, look at AVR, initial R wave, you're dealing with VT. Take note, in the middle, you actually have, I think that's a fusion beat. Now that's a capture beat, then you have followed by a fusion, then the regular tachycardia. Now, sometimes they will give you clinical situations. So a 32-year-old female with palpitations, previously healthy and a normal echo, and presents with this ECG, wide complex tachycardia, monomorphic. So this is actually ventricular tachycardia. You look at the morphology The chest leads, it has a left bundle branch block morphology. And then in your inferior leads, you have an inferior axis. That means your QRS are all pointed upwards, okay, going towards the inferior lead. This is an example of a right ventricular outflow ventricular tachycardia, one of your idiopathic VT. So you think of this when you have a relatively young patient with structurally normal heart that presents with this wide complex tachycardia. So your two idiopathic VTs are your RVOT VT, and the other one is your fascicular VT or your ILVT, idiopathic left ventricular tachycardia. So this is an ECG tracing of a wide complex regular tachycardia. And then you, okay, let's go back to that. But this time, again, you have a left bundle branch block morphology, then inferior axis. Okay, so this is RVOT VT. Another question. Now this time, 26-year-old, young patient, palpitation, previously healthy, also a normal echo. But unlike the previous two tracings, you have this time a right bundle branch block pattern. And then you have a left axis. Okay, so something like this. You have a left axis wherein you have a small r and a deep S that looks like a left anterior fascicular block. This is a VT with a RBBB morphology with a left axis. This is your typical fascicular VTA or ILVT using one of the fascicles. Okay, this is another form of your idiopathic VT. So idiopathic VTs usually can happen in young individuals with structurally normal hearts. Okay, in about 90%, it's RVOT VT. In about 10%, it's ILVT. Another example. Okay, wide QRS tachycardia, right bundle branch block, and then a left axis. No? So much like a left anterior fascicular block. So this is ILVT or fascicular VT. So the treatment here is, of course, the long-term treatment is ablation. That's curative. Short-term treatment, you can give verapamil actually for this VT. No? That's why it's also called as verapamil-sensitive ventricular tachycardia, your ILVT. On the other hand, the other one that we discussed earlier, RVOT VT, the curative treatment is also ablation, which is doable. Okay, then the acute treatment, that patient can respond to adenosine. That's why it's also called adenosine-sensitive ventricular tachycardia. And you can maintain the patient on a beta blocker or a calcium channel blocker. True or false? VT associated with the following portends a risk of sudden cardiac death. Okay, so dilated cardiomyopathy, yes. ARVD, yes. Idiopathic RVOT VT, no, that one's benign. Hypertrophic cardiomyopathy, yes. We have VT in HOCUM, that's a high risk for sudden death. What about congenital long QT syndrome? Yes, that is true. Brugada syndrome, if you have VT, yes, you have high risk for sudden death. Of course, fascicular VT, that's benign. So it doesn't increase risk for sudden death. Now, you need to know the indications for ICD implantation. Okay, so briefly, I'm going to list them down here. Of course, the guidelines have evolved, but basically the gist is would be the following: resuscitated VF, even without previous sudden cardiac death. If you have heart disease with sustained VT, or if you have a post-MI, low ejection fraction, and heart failure, that's already an indication. And of course, some of the other indications that you just need to be aware of. Okay, let's start off with a case. 32-year-old, previously healthy man, but this time arrested, resuscitated, VF on ECG stabilized, and on the ICU, you have this tracing. Okay, so the question is, what is the diagnosis? So this is an ECG. Okay, take a look at your V1, V2, and V3. So this is sinus rhythm, but you have this typical cove-type ST segment elevation. That is consistent with Brugada syndrome. So do not forget this ECG. Cove-type ST segment elevation in V1, V2. Okay? Brugada syndrome, your type 1 Brugada pattern. Recall question. Brugada syndrome is what? Is it A, B, C, or D? So it's a mutation of one of your channels. So actually the answer here is letter C. It's a loss of function mutation of your SCN5A, which involves your sodium channel. The opposite of the loss of function mutation, which is a gain of function mutation, is seen in long QT syndrome. Okay, so those are just pearls. Now, a couple of years ago, they showed something like this, which relatively looks normal. It's regular. There's a P wave followed by QRS. It looks regular, but be careful. And that's the reason why you have to measure your different intervals. So this one is a sinus rhythm, but this patient presents with a prolonged QT. Take note of the QT interval of this patient. And you have to know how to measure the corrected QT. So long QT syndrome presents with prolonged QT, usually in children and sometimes in adults. Okay? Typical long QT syndrome will present with a QT, corrected QT of more than 0.50. Of course, the cutoff is 0.46. Anything beyond that is prolonged. Now, the clinical significance, of course, your long QT syndrome is it might present with something like this. Okay? An ugly, wide complex, irregular, polymorphic ventricular tachycardia. So this is your torsade. Okay? A typical torsade. Do not forget. Okay, the typical morphology, consistent with its name, which stands for twisting of the points. This is from your book, again, showing torsade. No? Beautiful ECGs that seem to the axis seem to twist around a certain point. Okay, another example of one of the torsade ECGs. You can take note that in the upper tracing there are some sinus beats, but obviously with a long QT, and then there's a PVC there that precipitates a polymorphic ventricular tachycardia, consistent with the morphology of torsade. So you only call it torsade if the QT interval of the sinus ECG is prolonged. If it's not prolonged, then you just call it polymorphic VT. And you can actually describe it torsade-like features. But the typical T. Okay, a case. 56-year-old with ischemic heart disease, post-bypass, recurrent heart failure, low ejection fraction. They showed something like this a couple of years ago. So you have sinus rhythm, but this time you have a wide QRS complex, morphology consistent with left bundle branch block. So this is sinus rhythm with complete LBBB. So this is a patient with heart failure. Probably the side question there is, what is the definitive treatment for this patient? And the answer is CRT, right? So let's go to some of the questions on devices. Which of the following is included in the Class 1, Grade 1A recommendation for CRT? Yes, sinus rhythm, this one. EF less than or equal to 35%. Yes. LBBB, yes. That's a Class 1 indication. QRS duration, yes, the guidelines indicate 150 millisecond. And the patient should be NYHA Class 3 or 4 despite optimal medical treatment. Take note, it has to be despite optimal medical treatment. Okay? That means you have to start optimum heart failure treatment before you even attempt to put a device on this patient. Recall question, okay, related to that. Okay? The Class 1 indication for CRT, which of the following? I'll give you probably 5 seconds for that. So what is the answer? Okay, the answer is letter A. Okay, CLBBB, QRS duration more than 150, low EF on optimal medical treatment. All right. Now ARVD, just to show you the ECG, will present with this, okay, typical ECG in your right precordial leads, T-wave inversion. Okay, these patients are also at high risk for sudden death. Of course, try to remember the pathophysiology in RV dysplasia. you have a fibrofatty degeneration of your right ventricular wall. And so sometimes this patient might present with an epsilon wave, although it's not very common. A notch in the terminal part of the QRS, usually seen in lead V1. Okay, the typical epsilon wave, although the absence of that does not necessarily rule out. And this patient, since the pathology is in the right ventricular free wall, they present with a wide QRS tachycardia that is of a left bundle branch block pattern. Okay, so LBBB pattern. And it might mimic your RVOT-VT, wherein the axis is inferior. Some important points for our ARVD. Of course, one of the diagnostic criteria is to take a signal average ECG. Usually you'll have late potentials. I think a couple of years ago that was the side question, signal average ECG for ARVD. So take note of your bradycardias. No? So these are examples of pauses. So try to differentiate between what we call as a sinus pause or sinus arrest and an SA exit block. Okay, so the upper tracing. Take note of your P2P intervals. Okay, if the pause is not a multiple of the P2P intervals of the sinus beats, then you call that a sinus pause. On the other hand, if it's a multiple of the P2P interval, then that's an SA exit block. Okay, so you can clearly see SA exit block. Now, does the management matter? Well, not really. Okay, so they might just show you something like this, tracing with atrial fibrillation followed by long pause and then a junctional escape rhythm. So this is 6 sinus syndrome or sinus node dysfunction. Okay, so something like that. Atrial fibrillation with rapid ventricular response followed by long pause, junctional escape in the one below. Okay. 6 sinus syndrome, bradytachyarrhythmia, bradytachy syndrome. Okay, more tracings of 6 sinus syndrome. Okay, take note of the sinus bradycardia, pause, junctional escapes. Then episodes of rapid atrial tachycardia or fibrillation, alternating with pauses and episodes of asystole. 6 sinus bradytachy syndrome. Okay, this one's a little bit tricky, but you're presented with a slow, regular tachycardia. So always follow the algorithm. Look for your P waves. Look for your QRS in between. So obviously this one has P waves, slow QRS, but they're not related to each other. So this is your complete AV block. Now you have a wide QRS escape rhythm, which means that you have a ventricular escape rhythm. Okay? So this is complete heart block. Another example. This time you have a slow rhythm, regular. Do you see P waves? Yes. Do you see QRS? Yes, but there is no relation to each other. No? This is complete heart block, but this time with a narrow QRS, all a junctional escape rhythm. So in complete heart block, if your QRS escape rhythm is narrow, it's coming from the junctional tissue. If it's wide, it's from the ventricular. Okay? You might be tricked into this ECG because if you just read the initial part, you might misread this as 2:1 AV block. But actually, when you go to the last 2 beats, clearly you can see that there is AV dissociation, and those P's actually do not conduct to the QRS. Okay, another bradycardic rhythm, but this time it's irregular. Okay, take note, you go to the second beat, you have a P followed by a QRS that's wide, conducts with a right bundle branch block. The P conducts with a longer PR, then you have another P there that does not conduct at all. So this irregular prolongation of the PR interval, so that's actually second degree AV block, Mobitz type 1, RBBB. Okay, so what's this? Okay, you can clearly try it. It's a slow rhythm, regular. Look at the P waves. Look at the QRS. No relation to each other. It's complete heart block. Is the QRS wide or narrow? It's wide. So it's complete heart block with ventricular escape rhythm, similar to the tracing I showed earlier. On the other hand, this one has P waves, QRS in between, which is narrow, no relation to each other. This is complete AV block with a narrow QRS ventricular escape. Now, this is junctional escape rhythm. Okay, be familiar with 2:1 AV block and high-grade AV block. Okay, so anytime you have 3:1, 4:1, 5:1 conduction, you call that a high-grade AV block. Okay, be familiar with your AV blocks. All right. What does the top tracing show? The first 1, 2, 3, 4, 5, 6 beats has sinus rhythm, then followed by P waves, no longer followed by QRS. You have a episode of high-grade AV block. And the one below, they go back to high-grade AV block. Okay, so these are dangerous bradycardic rhythms. What's this? Okay, what you see are just P waves with no QRS complex. So this is a patient with ventricular asystole or ventricular standstill. Now, just some tips and tricks in complete heart block. Okay, the one on the left is complete heart block, but it presents with a narrow QRS escape rhythm. So usually these are blocks at or above the level of the AV node, or what we call a suprahesion block. And the escape rhythm is a junctional narrow QRS escape rhythm with a rate of 50 to 60 beats per minute. And these are usually benign. The one on the right is complete heart block, but this time a block below the level of the AV node, or what we call as infrahesion. It presents with an escape rhythm that is wide complex, ventricular, approximately slower, 40 beats per minute, originating from your Purkinje system, infranodal. This one is relatively dangerous, usually irreversible, and requires treatment in the form of a device. So what's this? Slow, regular, you have P's, you have QRS, no relation to each other, you have complete heart block. Okay, take a look at the QRS. Is it narrow or wide? It's narrow. So where's the escape? Junctional escape. So where's the level of the block? Suprahesion block. So complete heart block, suprahesion, junctional or narrow QRS escape rhythm. On the other hand, this one is also complete heart block. You have a slow, regular QRS complex that this time are wide in duration. So this is complete heart block, this time with an infrahesion block. And the QRS escape rhythm is ventricular or wide QRS escape rhythm. Okay, more tracings of your complete heart block, wide QRS escape rhythm. So infrahesion. What's this? So take note. There seem to be sinus beats followed by PVC. Then the next tracing is a sinus beat. And take note of this very bizarre looking T wave with a prolonged QT followed by a PVC that triggers a ventricular tachycardia that looks like a torsade. So pulse dependent or bradycardia dependent torsade or bradycardia dependent VT. So sometimes patients usually with complete heart block or high-grade forms of AV block, they might present with a prolonged QT. And then you can have these PVCs. This is a form of ventricular irritability that might trigger a ventricular tachycardia. And these patients, you do not treat with an antiarrhythmic. You pace them. So you have to insert a pacemaker because the tachycardia, the VT, is triggered by the bradycardia. All right. Now this is just one of those tricky ECGs wherein you have
Okay, you seem to have a 2:1 AV block. Then you have a right bundle branch block. And then take a look at your axis. Okay, left axis, you have left anterior fascicular block. So you have 2:1 AV block, complete right bundle branch block, left anterior fascicular block. Maybe it's a form of trifascicular block, right? So try to review your fascicular, your hemi blocks. Beautiful ECG. This is from your Bronwell. Okay, take note that this one is also a bradycardic rhythm, but it's a sinus rhythm. But then you have QRS that are wide that seem to change in axis, positive, negative, okay, variable axis, you have alternating right and left bundle branch block. So this one is also dangerous and is in fact is an indication for pacing in patients with heart block. Multiple choice. One of the following is a class 1 indication of permanent pacing in sinus node dysfunction. Which one is it? I'll give you 5 seconds to answer that. All right, so the answer is what? Letter B. Okay, so symptomatic chronotropic incompetence is actually an indication for permanent pacing. Okay, the others, the A, C, and D, are not indications. Multiple choice. Which of the following patients is a class 1 indication for permanent pacing? 5 seconds to answer that. Alright, so the answer is letter A. Okay, so anytime you have even a symptomatic third-degree AV block, but at the infrahis level, that patient is at high risk for syncope and needs to be paced. Alright. Okay, this one you need to know. No? What does the sequence of letters in the NBG code stand for? The NBG is the code for pacemaker nomenclature, stands for the NASPE, North American Society of Pacing and Electrophysiology, which is an old name, and your British Pacing and Electrophysiology group. So you have a series of numbers. Okay, the first number refers to the letter to the chamber being paced. The second letter is to the chamber being sensed. The third letter is the response to sensing, whether it's triggered, inhibited. Fourth is if there is a function of rate modulation. And forget about the fifth, not really usually included in that, no? But it stands for there are some pacemakers with anti-tachycardia pacing function. So that means, okay, take a look at let's go to pacemaker ECGs. When you say VVI, it's a single chamber pacemaker. So V, the chamber being paced, is the ventricle, and the chamber being sensed is the ventricle. And the response to sensing is inhibition. No? So that means if it senses a QRS complex, it will not pace. So it will only pace when it does not sense a QRS complex at a designated rate. This is the most commonly used pacing mode worldwide. Single chamber, or what I call the poor man's pacemaker. So it will just present to you with a Y QRS complex. All right. This is an example of a VVI pacing. Okay. Y QRS complex. Okay. So you have a pacemaker potential, the blip followed by Y QRS. It means it captured. So there's no sensing in the atrium. AAI, on the other hand, is also single chamber, but there's only one lead implanted into the atrium. Rarely do we use this alone. So it provides pacing and sensing in the atrium, and an intrinsic P wave inhibits atrial pacing. It has nothing to do with any sensing in the ventricle. Take note of that. So this one you only implant for patients with pure sinus node dysfunction with intact AV node. An example of an AAI pacing. Okay, it senses bradycardia in the atrium, it paces the atrium, and then it conducts with an intact intrinsic AV node conduction. Does not sense anything in the ventricle. Now, of course, the bread and butter for cardio fellows in this There's pacing both in the atrium and the ventricle, sensing both in the atrium and ventricle, and intrinsic P wave and intrinsic QRS can inhibit pacing, and there's a trigger for a pace QRS depending on a set interval. So the must-knows for you would be to distinguish the 4 distinct patterns of ECGs with DDD pacing. So there's what we call as A-sense, V-sense, wherein the patient has a normal sinus rhythm. So if the rhythm of the patient is sinus rhythm at a rate of 80, the pacemaker will not pace. So it's A-sense, V-sense. The second pattern is what we call as A-pace, V-sense. There's pacing in the atrium, but it conducts down through an intact AV node and senses in the ventricle. So atrial pacing purely. This is the mode that you see in patients with pure sinus node dysfunction and intact AV node. The third pattern is what we call as A-sense V-pace. There's sensing in the atrium, but it paces in the ventricle, also known as P-wave tracking or P-synchronous pacing. This is the mode that you see in patients who have heart block but have intact sinus node function. That means the sinus rate is intrinsic, normal, but because of heart block, it will trigger the pacemaker to pace in the ventricle. So A-sense V-pace. And of course, the last one is what we call as A-pace V-pace or AV sequential pacing. Pacing both in the atrium and the ventricle. And this is usually the mode you see in patients with both sinus node and AV node dysfunction. These are all examples of your DDD pacing. Okay, the one on top, the first one. What's this? This is A-sense intact P-wave V-pace. So this is P-wave synchronous pacing. Second tracing, this time is A-pace followed by V-sense. This is intact AV node. So this is A-sense V-pace. No, A-pace V-sense. Okay, so just atrial, pure atrial pacing. The third tracing this time is an AV sequential pacing. Okay, pacing both the atrium and the ventricle. While the fourth one is your typical sinus rhythm, A-sense, V-sense. No pacing at all because it's the patient's intrinsic rhythm is normal. So yeah, so that's your A-sense, V-pace, A-pace, V-sense, A-pace, V-pace, and lastly A-sense, V-sense. All right. These are just cartoons of your usual dual chamber ECG analysis. So this is an example of A-pace, V-pace. What about this one? Okay, the first few beats are A-sense, V-pace. And then this is followed by A-pace, V-pace. Okay, in the third and the second to the last beat. What about this one? Okay, so the first 3 beats are A-pace, V-pace, followed by A-sense, V-pace on the next 3 beats, and then reverted back to A-pace, V-pace. Okay, this is an example of your P-wave tracking. Okay, A-sense, V-pace. Now, one of the tricks I usually teach the fellows is when you have a pacemaker rhythm and its pacing seems to be at a fast rate, and you all know that pacemakers are usually set at a rate of 60, but why is this pacemaker pacing at a fast rate and it seems to follow the normal P waves? Okay, so that means you have a dual chamber and your pacemaker is pacing in an atrial sense ventricular pace mode. And this is the mode you see in patients with complete heart block. All right. Multiple choice. 75-year-old woman, dizziness. ECG showed complete heart block. During exercise, her sinus rate only goes to 90 beats per minute. Which of the following would be the optimal pacing mode for this patient? What do you think? Now, the key feature here is the patient has heart block, but you also have chronotropic incompetence. Okay, so you need a dual chamber that has rate response. Okay, so that's DDDR. Okay, favorite question. Magnet application of a pacemaker results in what? Okay, so the answer is C. It will pace asynchronously. So if it's a single chamber, it will pace in VOO. Dual chamber, it will pace in DOO, asynchronous mode of operation at a set rate. Okay, they might show you something like this. Hemodynamic tracing, and the upper part is ECG. This is during cath, no? The last 3 beats are paced beats, and they're functioning VVI. So the clinical setting is a 67-year-old lady with VVI pacemaker, still coming in with headaches, dyspnea. Angiogram was done, but incidentally, this was the hemodynamic tracing, showing you that blood pressure goes down during ventricular pacing. This is a typical example of pacemaker syndrome. All right. Pacemaker syndrome is often seen with which of the following pacemakers? What is the answer? So usually it is seen in single chamber VVI pacemakers. So in fact, that's one of the disadvantages of your VVI. Okay? True or false? True regarding pacemaker syndrome. Lack of AV synchrony due to exclusive ventricular pacing leading to hemodynamic impairment. That's actually the definition. It's caused by ventricular atrial conduction and atrial contraction against a closed AV valve. That is actually the mechanism. Is it exclusive to VVI pacing? No. It can sometimes occur in DDD pacing. Symptoms include malaise, lightheadedness, typical chest discomfort. Yes, that's part of the clinical features. And ideal treatment involves changing from a single chamber to a dual chamber pacemaker. So that's the solution there. Which of the following is a physiological pacemaker? Atrial inhibited, ventricular inhibited, synchronous, triggered. So the physiological pacemaker here is your atrial inhibited. In fact, the most physiological pacemaker is an AAI. But conventionally nowadays, we do not implant a pure AAI because in about 15 to 20% of patients with sick-sinus syndrome, they might later develop AV block. And hence, your pacemaker becomes useless. So we usually implant a DDD, and you have the option of setting it just to an AAI mode. The optimal mode of pacemaker for a 77-year-old active man with chronic AF and complete AV block. Yes. So the key word there is you have chronic AF, you no longer need your AV synchrony. And so the answer is a VVI. All right? True or false? The following are possible causes of failure of pacemaker to capture. High thresholds? Yes. Fracture? Insulation defect? Lead dislodgement? Yes. Failure to capture. Functional not capture? Yes. All of them are true. The following are causes of failure of the pacemaker to sense. Lead dislodgement, insulation failure, circulation failure, magnet application, of course, blah, blah, blah. All of these are true. Okay, so just read on them. Let's go to some pacemaker ECGs. What's happening here? So you read it from left to right. So you actually have a pacemaker blip followed by a white QRS complex. That means it's captured. The second one is a pacemaker potential followed by a white QRS. Then you have a PVC. Now after the PVC, you have this another blip followed by another white intrinsic PVC, white intrinsic QRS. Then you have another blip. That means your pacemaker is not sensing, poor sensing. But there is capture, right? Okay, read it from left to right. The first beat is a PVC. Then followed by a paced beat. And then there's another PVC. And oops, there's another paced beat. but it should not pace at this interval because you just had a PVC. So that means this pacemaker is not sensing. So this is poor sensing. Now this time you have, okay, read it from left to right, wide QRS, intrinsic beat. You have a pacemaker potential but no capture. So this is failure to capture. What about this? Okay, the two beats in the middle clearly are paced beats followed by a capture, but you wonder what happened in between. Okay, there's a long pause, so that means the pacemaker is not sensing this long pause, and in fact might be over sensing these artifacts. Okay, this is what we call poor sensing or over sensing. Okay, this might happen when you do cautery during surgery and your pacemaker is sensing the cautery signals as electrical signals. So again, the first three beats are paced beats, good capture. And then you have this long pause, wherein the pacemaker does not sense this interval. So there's poor sensing, and actually the pacemaker is over sensing this particular T wave after the third beat. So it's sensing it as a QRS, hence there's a longer delay. Aha! Again, first beat is a paced beat followed by capture, and then a pace blip, no capture, and then there's no sensing followed by normal pacing again. So you have intermittent over sensing and you have intermittent poor capture. Okay, so these are all lead dysfunctions. Okay, so what is this tracing? Okay, clearly this is a pacemaker rhythm. You have a pacemaker spike, YQRS complex. The next question to ask, is this a single or a dual chamber? Take note that it does not seem to sense any activity in your atrium, and it's purely pacing in the ventricle. This is pacemaker rhythm with VVI pacing mode, good sensing and capture. On the other hand, again, this is a paced rhythm. Look at those pacemaker potential, followed by capture. And I mentioned earlier, you have something like this, pacemaker rhythm, but the rate seems to be more than 60. And the paced beats seem to follow an intrinsic P wave. Okay, so this is your pacemaker rhythm that's dual chamber, atrial sensing ventricular pacing function with good capture. Okay. Okay, last tracing is again paced rhythm. It's regular, but you can clearly see you have a paced QRS that follows an intrinsic P wave. No? So this is a dual chamber pacemaker. A sense, V pace. Okay, so don't forget the tips and tricks. Okay, multiple choice. Endless loop tachycardia is a problem often seen with what particular mode? So endless loop tachycardia is one of the problems you can see in a DDD. Okay, so this particular problem can lead to a YQRS tachycardia, which I mentioned earlier, a pacemaker-mediated tachycardia that might mimic a VT. Okay, this is an example of an endless loop pacemaker-mediated tachycardia. So not all pacemakers are foolproof. It can trigger a tachycardia because of certain intervals set within the device. So in any pacemaker capable of P-synchronous pacing, also known as pacemaker reentrant or pacemaker-mediated tachycardia. Just a brief discussion of what happens in PMT. So when there's a PVC, there's a loss of AV synchrony. So there's a PVC which conducts retrogradely to the atrium. And what happens is it sets off a signal in the atrium. Initiates an AV interval with a prolonged AV interval and conducts down the ventricle, paces the ventricle, and then once it paces the ventricle, it causes retrograde conduction back the AV down up to the atrium, which triggers a circuit, and repetition of that will lead to pacemaker mediated tachycardia. Right? So it's actually a form of reentry, but this time using the pacemaker as part of the circuit. This is an example of a pacemaker-mediated tachycardia. One of my patients, Holter. Okay, you can clearly see it might mimic your ventricular tachycardia. So I think a couple of years ago, one of the questions in the SBAC was, what would be the treatment for pacemaker-mediated tachycardia? So the treatment is to increase the post-ventricular atrial refractory period to about 320 milliseconds or more. That means you increase the period wherein your atrium will not sense any retrograde conduction. Or some pacemakers have what we call as PMT detection algorithms. It will try to detect that the pacemaker seems to be going into PMTs and will try to sort of correct some of the intervals so that you will prevent PMTs. Now, a couple of years ago, one of the questions was something like this. And what would you do if you don't have a programmer? Well, the next best thing you can do is just put a magnet over the pacemaker, and it might just pace in DOO, and you might be able to terminate the PMT. All right. The most common electrolyte abnormality causing sensing and threshold problems in patients with pacemakers is giveaway question. Of course, it's hypo-K. That's why you always check the potassium, no? If you have sensing and threshold problems. Type of pacemaker setting seen least likely associated with development of AF. So the answer is AAI. And that's the most physiologic pacemaker, because you're just pacing the atrium and you're using the intrinsic AV conduction, and you allow for AV synchrony to happen. All right, recall question. Which NYHA functional class will most benefit from CRT? This is based on the trials. For CRT, the ones most to benefit would be your class 3. Okay, heart failure patients, not your class 4. Class 3 has better prognosis. Now, what about ICD? For ICD, those who will most benefit would be your class 2. Okay? And that's shown in your MADIT trials, a different meta-analysis. Which heart failure etiology will most benefit from a CRTD? So CRTD usually will benefit most your non-ischemic cardiomyopathy, your dilated cardiomyopathy. On the other hand, those that will benefit most from an ICD would be your ischemic ones, as shown in your Danish trial. No? So usually the post-infarct one are the ones that benefit from your ICD. A 20-year-old male, palpitation showed the following ECGs. This is a recall question. So on the left you have a WPW ECG, on the right you have SVT. So what is your complete diagnosis? WPW syndrome. Most likely mechanism, re-entry. What is the definitive management? Definitive management for this patient would be ablation of the pathway. Another recall question. 60-year-old female on diuretics. Okay, that's important clinical data. An antiarrhythmic drug was brought in due to seizures, and your ECG shows this. You have runs of polymorphic VT. All right, so what is your complete ECG diagnosis? Actually, your VT is polymorphic. It looks like torsade. So this is torsade. Plan of management: correct the electrolytes, check the electrolytes because your patient is on diuretics. And in order to manage the torsade, you can give your magnesium sulfate. Right? All right. 45-year-old male, sudden onset pleuritic chest pain. No? So be aware of the clinical clues on the question, and dyspnea. ECG shows sinus tachycardia. And since you have the data of pleuritic chest pain, what are you thinking of? Pulmonary embolism. Well, take note of the findings of pulmonary embolism. Okay, your deep S1, the Q3, T3. Oh, so this is pulmonary embolism. I know a question like this is unfair, but a couple of years ago it was shown. What is the mechanism of RVOT-VT? This is from your books. Is it early after depolarization, delayed after depolarization, reentry, automaticity? RVOTVT is early after depolarization. Okay. Now your delayed after depolarization, that's your example for your digitalis toxicity. Okay. Alright, miscellaneous stuffs to review, which I leave to your reading, would be the following. No? So the ECGs for acute coronary syndrome, how to identify the culprit lesions based on your ECGs. Alright. Of course, ECGs of hyperkalemia, hypokalemia, pericardial effusion. Okay, try to review those, CNS disorders, and endocrine diseases. Now, just to show you some x-rays in case they will show you, this is what a pacemaker looks like. This is a dual chamber pacemaker. 2 leads, one into the right ventricular apex and another one into the right atrium. This is an example of an ICD, huge device. You can see this ventricular lead with these 2 coils. Distal coil and a proximal coil, which is in the area of the SVC. So you see something like this, you know it's an ICD, defibrillator lead. So it's dual chamber, you have another lead implanted into the right atrium. Alright? Now, when you have 3 leads, okay, you have the 3rd lead, which is a left ventricular lead, implanted into the coronary sinus into the one of your coronary veins or your cardiac veins. So this is CRT. Cardiac resynchronization therapy, or a biventricular pacemaker with an ICD. You know there's an ICD because of this coil in your right ventricular lead. What is this? Just for you to know, it's a pacemaker lead, and then you have evidence of a fracture there. Okay? So one of the problems when it comes to pacemakers is a fractured lead, which might lead to problems in sensing and capture. Now, several last slides, just in case they will show you an intracardiac electrogram. So this is what is seen during an electrophysiology studies. The first 3 tracings are ECG leads, then followed by your electrogram, okay, intracardiac electrogram. So you have catheters placed in the high right atrium, then the bundle of His, both the proximal and the distal electrodes, and then you have several electrodes in your CS, and then lastly you have a right ventricular apex. I think the must-know electrogram for you is the one in the middle, this one, His proximal. Okay, it's an electrogram that consists of 3 squiggles. Okay, your A, sharp H, and then your V. So take note of the His bundle electrogram. All right. And the reason for that is we usually measure those particular intervals, particularly your HV interval, okay, the one in the middle, His bundle. So H from the onset of the H until the onset of the ventricular electrogram, that's your HV. And nice to know, the normal HV interval is 30 to 55 milliseconds. Anything beyond 55, that means you have some AV node disease, infrahition. Okay. On the other hand, anything less than 30, that's what is usually seen in patients who have a bypass tract or pre-excitation. So be familiar with your cardiac electrograms. This is another example of your.
So this is an example of an intracardiac electrogram. So the last 2nd to the 3rd bottom tracings are your His bundle electrogram, and you can clearly see the A, H, and the V signals, right? So be familiar with your His bundle electrogram. Another example, okay? Take note of your His bundle electrogram. This is a patient with sinus rhythm. Okay, your A, H, and the V signal. Okay, potential side question, which of the following is an expected EPS finding in a patient with WPW syndrome? So that's pre-excitation, and that will mean a short HV interval. Most of the time, the HV intervals in these patients are negative, no? As seen here. Okay, you can clearly see the His bundle electrogram is the one in the middle. Okay, very short HV interval, sometimes negative. Which of the following is an expected EPS finding in a patient with heart block? This time, that we will be dealing with a prolonged HV interval, or D. No? So that's prolonged HV. So I guess I'll leave the other review up to you. It's already brain overload at this time. Just some final tips. Maybe the proper thing to do one day before the PCC would be what? You want to cram some more, fish for tips, call the secretariat to confirm if exams will push through, pray. I guess the most important thing to do is pray. Okay, my personal tips to nail the PCC. Only 5% will come from your review. A little will come from last-minute cramming, 20% stock knowledge, and the remaining would rely on common sense, and of course 100% prayers. So I bid everyone good luck, and I shall pray that you all make it. Good luck, everyone, and may the force be with you always.